Pulmonary tuberculosis begins when airborne Mycobacterium tuberculosis reaches the alveoli after inhalation.
The alveolar macrophages phagocytose the bacilli, which survive inside macrophages by preventing intracellular destruction and begin multiplying. Cell-mediated immunity by CD4 cells organizes macrophages into granulomas that contain the infection. Persistent immune activation produces characteristic caseous necrosis within the tuberculous granuloma. Primary pulmonary tuberculosis produces a GON focus, the initial pulmonary lesion, with associated hilar lymphadenopathy forming GON complex. In latent tuberculosis, viable bacilli remain dormant within calcified granulomas without active disease. Reduced immunity allows dormant bacilli to reactivate, producing active pulmonary tuberculosis.
Drainage of liquefied caseous material produces the characteristic cavitary lesion of pulmonary tuberculosis.
Active pulmonary tuberculosis presents with chronic cough, fever, weight loss, night sweats, and hemoptysis. Untreated pulmonary tuberculosis spreads through airborne droplets, released during coughing, sneezing, or speaking. Mycobacterium tuberculosis is an obligate aerobe and preferentially multiplies in the oxygen-rich upper lobes of the lungs.
Untreated tuberculosis progressively destroys normal lung architecture through inflammation, necrosis, and fibrosis.
Tuberculosis may disseminate through the bloodstream to involve multiple organs like brain, bones, kidneys, vertebra, glands, liver, spleen, and bone marrow. Massive hematogenous spread produces miliary tuberculosis, with innumerable scattered tiny granulomas throughout the body. Tuberculosis involving the pleura produces pleural inflammation, and exudative pleural effusion, which is rich in lymphocytes, protein, and ADA, adenosine deaminase. Caseous material entering the bronchi spreads infection to previously unaffected regions of the lung, giving the typical tree and buds appearance on CT scan. Erosion of pulmonary blood vessels by cavitary tuberculosis causes Rasmussen pseudoaneurysm, resulting in hemoptysis. Successful immune containment initiates healing, which occurs through fibrosis and calcification, leaving permanent, firm, calcified pulmonary scars. Extensive pulmonary destruction severely impairs gas exchange, leading to respiratory insufficiency. Pulmonary tuberculosis progresses from inhalation to granuloma formation, then to latency, reactivation, and cavitation, or chronic lung destruction. Pulmonary tuberculosis should be suspected in patients with chronic cough, fever, weight loss, night sweats, and hemoptysis. CXR in pulmonary TB commonly demonstrates upper lobe infiltrates or patchy consolidation, thick-walled cavitation, fibrosis, and hilar lymph nodes. HRCT detects early pulmonary TB and demonstrates centrilobular nodules, bronchogenic spread with bronchiectasis, in exceptional detail. 3 early morning sputum samples, with proper collection of an adequate sputum specimen, is required of microscopic confirmation.
Zeal-Nielsen staining identifies acid-fast bacilli by their characteristic bright red appearance.
Fluorescent microscopy by auramine staining increases sensitivity, rapidly detecting acid-fast bacilli, which emit brilliant yellow-green light.
GeneXpert is real-time PCR technology rapidly detects Mycobacterium tuberculosis DNA and identifies rifampicin resistance within hours.
Culture by Lowenstein-Jensen medium and liquid MGIT culture tubes is the gold standard test for tuberculosis and enables comprehensive drug susceptibility testing.
Drug susceptibility testing for rifampicin, isoniazid-Ethambutol, pyrazinamide guides individualized therapy by identifying antimicrobial resistance.
Accurate diagnosis combines clinical evaluation, imaging, microbiology, molecular testing, culture, and drug susceptibility testing and guide effective pulmonary tuberculosis. Drug-susceptible pulmonary tuberculosis is treated with an intensive 4-drug regimen, HREZ, for 2 months, and then 2 drugs, HR, for 4 months. Isoniazid inhibits mycolic acid synthesis, destroying the protective cell wall of Mycobacterium tuberculosis. Rifampicin blocks bacterial RNA polymerase, preventing RNA synthesis and rapidly killing actively multiplying bacilli. Unlike other drugs, pyrazinamides diffuse into acidic lesion. It is highly effective against dormant bacilli surviving within acidic caseating granulomas.
Ethambutol inhibits arabinosyl transferase enzymes and arabinogalactan synthesis, weakening the mycobacterial cell wall and limiting resistance.
During the intensive phase, bacterial numbers fall rapidly, and pulmonary inflammation begins to resolve.
Continuation therapy eliminates persistent organisms and minimizes the risk of disease relapse.
Multi-drug-resistant tuberculosis develops when bacilli become resistant to at least isoniazid and rifampicin. Drug-resistant tuberculosis requires individualized multi-drug therapy. This is based on susceptibility testing. It also requires specialist management. With timely diagnosis, appropriate therapy, and treatment adherence, most patients with drug-susceptible achieve microbiological cure and significant clinical recovery.
Pulmonary tuberculosis is a highly contagious bacterial infection caused by Mycobacterium tuberculosis, primarily affecting the lungs. It remains a significant global health challenge, with millions of new cases and deaths annually. Certain groups, including those with compromised immune systems or specific health conditions, are at higher risk. The pathogen, Mycobacterium tuberculosis, is an airborne, slow-growing bacillus. Its unique cell wall, composed of components like mycolic acids and lipoarabinomannan, provides extreme resistance to environmental stress and drugs. This pathogen is highly contagious via coughing, not through food or water. The infection cycle begins with the inhalation of bacilli, which are engulfed by alveolar macrophages. The bacteria survive and multiply intracellularly, eventually spreading to lymph nodes. The body responds by forming granulomas, a critical step in containing the infection through an immune response. Tuberculosis presents differently depending on the stage. Primary TB often affects children and newly infected adults, frequently remaining asymptomatic. Secondary or post-primary TB results from reactivation or reinfection, typically targeting the upper lobes of the lungs where oxygen levels favor the growth of the bacteria. Clinical manifestations of TB include systemic symptoms like fever, night sweats, and weight loss, along with localized respiratory issues such as a chronic cough and hemoptysis. Physical examination may reveal specific sounds during lung auscultation or signs of advanced disease in more severe cases. Accurate diagnosis involves various modalities. Sputum smear microscopy offers quick results, while GeneXpert tests provide high sensitivity for rapid detection. Culture tests remain a gold standard for confirmation, though they require a significantly longer turnaround time. Modern diagnostic standards utilize both molecular and traditional methods. While staining techniques like Zeal-Nielsen remain frontline tools, molecular diagnostics like cBNAAT are critical for quickly identifying TB and drug resistance. Specialized tests like IgRA also aid in assessing immune responses. Radiological imaging is vital for TB diagnosis. Chest X-rays can reveal characteristic features of primary or secondary TB, while CT scans offer higher sensitivity, clearly showing structures like tree and bud nodules, consolidation, and other markers of disease activity. Diagnostic evaluation also includes testing for latent TB, such as the tuberculin skin test and blood-based IgRA tests. These indicate exposure but do not confirm active disease. Differentiating TB from other conditions like lung cancer or pneumonia is essential for correct clinical management. The standard treatment regimen is divided into 2 phases. The intensive phase uses 4 drugs over 2 months to rapidly reduce the bacterial load. The continuation phase uses 2 drugs for 4 months to eliminate remaining bacteria and prevent relapse. The efficacy of TB treatment relies on the specific mechanisms of action of these first-line drugs. Each medication targets different bacterial processes, from blocking cell wall synthesis to halting genetic transcription, working together to systematically destroy the infection. Effective TB treatment requires careful management of drug toxicities. Medications like isoniazid, rifampicin, pyrazinamide, and ethambutol can cause side effects ranging from liver issues to visual disturbances. Regular monitoring is necessary to ensure patient safety and adherence throughout the therapy. Drug-resistant TB requires a departure from standard protocols. Detection of resistance to primary drugs mandates the use of specialized, longer-term regimens tailored to the specific resistance profile, guided by drug susceptibility testing and established public health guidelines. Untreated or inadequately managed TB can lead to severe clinical complications, including massive hemoptysis, structural lung damage, and systemic dissemination. The infection can spread beyond the lungs, potentially affecting the brain, spine, and other vital organs. Global TB elimination requires a multifaceted public health strategy. This includes early clinical intervention, strict environmental controls, and community-wide defenses like contact tracing and vaccination programs. A coordinated effort is essential to stopping transmission and protecting public health.
Pulmonary tuberculosis is a chronic granulomatous infectious disease that systematically destroys the lung parenchyma. The infection is driven by the Mycobacterium tuberculosis complex. This pathogen travels inside microscopic airborne droplet nuclei, often just 1 to 5 microns across, carrying a slender red bacillus directly into a new host. The scale of its clinical impact is massive. The bacteria causes over 10 million new cases and upwards of 1.5 million deaths globally every single year. Mastering the clinical management of this disease requires reverse engineering the pathogen's biological life cycle. We have to understand its unique lipid armor to deploy the exact multi-drug pharmacology required to break it apart. This is a modern, continuously evolving clinical challenge. Curing it demands a precise, cellular-level understanding of how the bacteria operates. India currently carries the highest number of tuberculosis cases globally, making it the central battleground for disease elimination. The fight relies heavily on community-level clinics to identify and treat patients where the spread is highest. Transmission is entirely airborne. When a patient with active cavitary disease coughs, highly infectious droplet nuclei are expelled into the air, ready to be inhaled. The bacteria capitalizes on vulnerable immune systems. Immunosuppressive conditions, specifically HIV infection, diabetes mellitus, and severe malnutrition, drastically accelerate a person's susceptibility to the infection. It is strictly a respiratory threat. You cannot contract it through food, contaminated water, clothing, or physical contact like handshakes. Tuberculosis thrives on shared air and weakened immunity. That combination provides the exact conditions the bacteria needs to invade the host. Biologically, Mycobacterium tuberculosis is an obligate aerobe. It is non-motile and notoriously slow-growing, requiring roughly 18 to 24 hours just to complete a single generation cycle. This diagram shows a cross-section of its defining structural feature, an extraordinarily lipid-rich cell wall. We start here at the inner plasma membrane. Building outward, the bacteria lays down a foundation of peptidoglycan, followed by a thick structural layer of arabinogalactan. On top of that sits the primary defensive shield, mycolic acids. This waxy lipid layer provides the organism with severe resistance to drying out and to standard antibiotic penetration. Embedded within this matrix are specific virulence factors, including lipoarabinomannan and cord factor, which actively aid in the pathogen's intracellular survival. This dense lipid composition is exactly why the organism holds on to specialized laboratory stains, giving it the clinical designation of an acid-fast bacillus. Because of this thick, waxy armor, standard broad-spectrum antibiotics fail against the bacteria. We have to use highly targeted drugs to break it down. When those droplet nuclei are inhaled, they travel deep into the respiratory tract, eventually settling in the terminal alveoli of the lungs. The host's initial immune response deploys alveolar macrophages, which immediately attempt to engulf and destroy the invading bacilli. Looking closely at this internal cell view, we see a survival paradox. The bacteria uses its cell wall to actively block phagosome-lysosome fusion. By preventing the macrophage from releasing its oxidative chemicals, the pathogen survives safely inside. Now protected inside the host's own immune cells, the bacteria multiply and spread through the lymphatic system, draining directly into the hilar lymph nodes. This diagram maps out the resulting primary or GON complex. It consists of three specific anatomical components: the initial local GON focus, the draining lymphatics, and the enlarged hilar lymph nodes. It takes 2 to 8 weeks for a delayed cell-mediated immune response to finally trigger. CD4 T cells activate, releasing interferon gamma and tumor necrosis factor alpha. This cytokine release drives the formation of a caseating granuloma, a walled-off cellular prison made of epithelioid and Langerhans giant cells surrounding a core of necrotic tissue. The immune system manages to wall off the indestructible pathogen, but it cannot clear it. This creates a precarious latent state that can reactivate if the host's immunity ever drops. Primary TB is often entirely asymptomatic and localizes in the lower or middle lung zones. Secondary or post-primary TB is a highly destructive reactivation. This 3D lung model illustrates why secondary TB almost always targets the apical and posterior segments of the upper lobes. Mycobacterium tuberculosis is an obligate aerobe, meaning it seeks the areas with the highest oxygen tension. Because of rapid multiplication in these upper lobes, chest X-rays and CT scans will show extensive tissue destruction, revealing thick-walled cavities, severe fibrosis, and subsequent bronchogenic spread. Patients experience profound constitutional symptoms: an evening rise in temperature, drenching night sweats, chronic fatigue, and extreme weight loss. Locally, this damage presents as a chronic cough lasting more than 2 weeks, heavy sputum production, and hemoptysis, or coughing up blood. If left unchecked, complications escalate rapidly to massive hemoptysis, extensive lung destruction, or miliary dissemination, where the bacteria spreads systemically. The bacillus literally consumes host lung tissue to fuel its own aerobic replication, directly driving the patient's severe clinical decline. To confirm the clinical suspicion, sputum examination remains the single most critical first step in tuberculosis investigation. Under direct smear microscopy using a Zeal-Nielsen stain, you can clearly see the acid-fast bacilli appearing as bright red rods against a blue background. While this method is highly accessible and rapid, its low sensitivity means many active cases go completely undetected. Modern clinical practice relies on highly precise molecular diagnostics to solve this, utilizing platforms like CVNAT, commonly known as GeneXpert, and TrueNet. This diagram illustrates how CBNAT rapidly detects Mycobacterium tuberculosis DNA directly in the raw sputum sample. Crucially, it performs simultaneous detection of genetic mutations that cause resistance to rifampicin, delivering actionable answers in roughly 2 hours. This rapid test contrasts with liquid culture methods, which take 7 to 21 days, though culture remains the absolute gold standard for comprehensive drug susceptibility testing. It is important to note that tuberculin skin tests and interferon gamma release assays only prove historical exposure to the bacteria. They indicate latent TB, not active clinical disease. Molecular testing allows clinicians to move past merely visualizing the bacteria, providing instant access to its genetic vulnerabilities so targeted treatment can begin immediately. Treating drug-susceptible tuberculosis demands a strict multi-drug approach, an intensive phase of 4 drugs for 2 months, followed by a continuation phase of 2 drugs for 4 months. First, isoniazid blocks outer mycolic acid synthesis, stripping the lipid shield. Next, rifampicin penetrates, halting DNA-dependent RNA polymerase to stop replication. Pyrazinamide uniquely activates in the acidic macrophage environment, killing intracellular bacteria. Finally, ethambutol inhibits the arabinogalactan layer, triggering total cell wall collapse. This aggressive therapy carries major toxicities that must be actively managed. Isoniazid can cause peripheral neuropathy. Rifampicin turns body fluids orange. Pyrazinamide carries heavy hepatotoxicity, and ethambutol risks optic neuritis. This multi-pronged, simultaneous biochemical assault is the absolute minimum pharmacological pressure required to overcome the pathogen's extremely slow growth cycle and dense cellular armor. When treatment protocols fail, the bacteria adapts. Multi-drug-resistant TB, or MDR-TB, occurs when strains develop genetic resistance to at least isoniazid and rifampicin, necessitating highly complex, specialized regimens. Public health measures are the first line of defense. Historically, the BCG vaccine has been crucial in protecting infants and young children from severe, disseminated forms of the disease. Today, early molecular diagnosis, strict adherence to treatment regimens, and aggressive contact tracing are the only mechanisms we have to prevent community transmission and stop the rise of extensively drug-resistant strains. Conquering pulmonary tuberculosis relies entirely on an unbroken chain of clinical logic. You must respect its lipid armor, anticipate its immune evasion, and aggressively break its synthesis pathways through exact molecular precision.